Good morning, everybody. Welcome to Grand Rounds. It's 12:01, so I think we're going to get started. Today's presenter is Dr. Alnoor Ramji, and one of our hepatologists, and is representing the Division of GI, and I can see many of you are also representing the Division of GI, since I recognize some of you from the GI area. Alnoor's talk today is going to be on hepatitis C and NASH. So, Alnoor? Do you want to use this?
Yeah, I guess I should. Thank you.
Yeah, should I use it on? Yeah, thank you.
Okay, thank you. Okay, so thanks for coming out. I know it's the middle of spring break, which is always challenging, and it does lead to many fun things outside. So I was asked to give a talk really on hepatitis C and NASH, and the way this came about is essentially what should we talk about in the era of hepatology, in this era of hepatology, how have things changed, and what are we going to look forward to in the future? I've given talks on hep C, as you know, I've given talks on fatty liver disease, but really where are we and where are we going? And I've been very fortunate, given when I started liver diseases, I could see most of the era of hepatitis C and see how much has changed, and now to look at a newer disease, which has been amazing, and hopefully you'll be able to get as much excitement out of this as I have had. These are my disclosures, particularly in the context of clinical trials more than anything else. So we're going to talk about hepatitis C, and really the objective today is to be able to review, at least briefly, the natural history of hep C, as well as the burden of the disease we face in BC in particular, look at the efficacy and the impact of curative hep C therapies, not only on the person itself, but potentially societal, and then review the challenges that we have in hep C, which is more so in the context of linkage to care than anything else in hep C. And there are a few requests that are important here, and really it's going to come in the context of the linkage to care aspect. As background for any type of liver disease, we have to think about the natural history of liver disease. Hepatologists, by virtue, are very simple-minded persons. And we look at fibrosis of the liver, and you have stages of fibrosis. Stage 1 fibrosis is minimal fibrosis. Stage 0 should really be which is no fibrosis, which is hopefully most of us. And then as you progress on into getting more fibrosis, you get cirrhosis. And cirrhosis is really marked at the point of stage 4 fibrosis. And if you look at the distances between these lines, they're actually purposefully done. The distance between stage 1 and 2 is greater than stage 3 and 4. What it means is, as you progress onto more significant fibrosis, from moderate to extensive fibrosis, that time lag is shorter. So once you get to moderate fibrosis, you're at a faster progression of liver disease. Anytime anybody has liver disease, they come to you and say, well, my toe is hurting. And really, liver disease should not give you any particular symptoms. Most patients are asymptomatic unless they're really cirrhotic. And when you're cirrhotic is when you have an increased risk of liver cancer for the most part, or risk of death per se from decompensated liver disease. How many people have hepatitis C in Canada? Well, unfortunately, the numbers are quite vague, as you see on there. We estimate 1%. It depends on where you're actually looking at, in which province and which suburban areas you're looking at. But it's thought to be anywhere between 250,000 is a conservative measure, but up to 400,000 people in Canada with hepatitis C. This is a study we did a few years ago, and really this was modeling data. It was modeling data done in 2013 to look at the prevalence at that time to see what the future would be looking out to 2035. And in y-axis, we show the prevalence rates of these different end factors, really, or endpoints. Compensated cirrhosis will increase by 90% by 2035. Decompensated liver disease, so any aspects of true liver failure, by 80%. Liver-related death, 160%, and liver cancer, 200%. And this is looking at 2013, not integrating as much of the treatment at that point as there was today. So when we look at treatment of hepatitis C, as you know, the treatment of hepatitis C is probably one of the most significant advances when you look at therapeutics in a medical perspective over the last 2 or 3 years. On the y-axis is the SVR12, which is the same as a cure. So this is the cure rate. And this is different eras of hep C therapy. So up to 2011, most patients had a cure rate of about 16%. Between 2011 and 2014, the cure rate went up into the mid-50s. And then presently it sits at about 95%. So 95% of patients who have Hep C can be treated and cured of their Hep C. And when I say cured, it's gone forever, so it is gone. So when you look at the different treatments, and this is just to give an idea, there are a number of different treatments which are available. And in BC, all these treatments are completely funded by the province, i.e. it is free for everyone. So anybody who has Hep C has access to these Hep C treatments. And they cost, well, the label cost is about 45 or 50,000. Obviously, there's a deal bought into that where the cost is much lower. The majority of these treatments are 12 weeks in duration, and all these treatments are oral. So they're all oral regimens. They used to be interferon-based, and that's when the fear of Hep C treatment came in, was the side effects of interferon. The regimens are taken for 12 weeks. They're highly efficacious, 95% cure rate. And really, when you look at the AEs or the side effects, it's the same as placebo. So we almost have to make up side effects to tell the patients so they'll actually believe they're getting something. You know, everybody gets some abdominal discomfort on any pill you get. So maybe a bit of abdominal discomfort, maybe a bit of headaches, but nothing significant per se. So the question is, from clinical trials, you can get 95 and 98% cure rates. Is that what we can see in real world? And the answer is essentially yes. I'm just giving you one example of efficacy rates. This is from the US TRIO network. The TRIO network is academic as well as community clinics. And they look at 8,000 patients who initiated treatment in 2016. We don't care what the names of the drugs are because they're all very effective. And if you look on here, these are all the types of cirrhotics and non-cirrhotics, HIV patients, transplant patients. Overall, whoever you treat, the overall cure rate is 95%. So people do really very well. But this is the more interesting part of what these guys presented. So 8,000 patients, and if you look at how they followed on these patients on treatment, 4% just discontinued, 90 patients died, 7,600 completed treatment, but only 7,000 actually had cure assessed. So that's what the number you should be looking at. Only 7,000 actually completed treatment to the point where they followed up and had cure assessed. So if you look at the best possible cure rate in the real world population from this data set, it's actually 87%. So what I normally say at this point is that the drugs work. It's humans who really fail in the situation, right? Because either we're not following these patients or something else happens along the way. And the cure rates from the drugs itself, if everybody took it and followed up, was going to be 95%. But due to reality of life, it really comes down by that 13%. And if we were to do anything to actually impact this cure rate, is really to impact this flow of how we can optimize the patients and strategies to optimize the patients going through treatment and completing it. So when we cure Hep C, it's very nice. You hug each other and say, well, congratulations, pat on the back, Hep C is gone. But does it mean anything else when you look long term? So without a doubt, treating Hep C simply saves lives. This is the y-axis looking at all-cause mortality. So this is not liver-related mortality. This is any cause of death. And this is time in x-axis. And there are multiple studies that have shown that this is one meta-analysis. Patients without a cure and patients with a cure. And you see the significant benefit on all-cause mortality by treating Hep C. What about liver cancer? So the liver, as you hopefully know, is the smartest organ there ever is and ever will be. Smarter than the skin or anything else because the liver can regenerate. When you regenerate, you may decrease risk of things like liver cancer. So cure actually results in decreased liver cancer rates in the cirrhotic patients treated and cured. So on the y-axis, risk of HCC, even though you have to remember this looks at 100%, so it would have been nicer to show it up to just 20%. You would have seen this huge difference. But the risk of liver cancer goes up to 18% in a cirrhotic patient. But when you cure them, the risk of HCC goes down to about 4%. It is not zero, which is very important because a lot of people will treat Hep C and forget about the cirrhosis. And what I'm used to seeing now is patients who've been treated for Hep C previously and they come in and have liver cancers. So even if you have been treated for Hep C, doesn't mean your liver is normal. You may get a bit better. But particularly if you're cirrhotic in the past, you need to be screened for liver cancer indefinitely. But curing Hep C decreases the risk of liver cancer. For the internists, this is going to be particularly important. This is from the VA data set, and they have 17,000 matched and unmatched controls of treated and untreated patients with Hep C. And even treating Hep C shows an improvement in the overall risk of cardiovascular mortality, or cardiovascular events, after treatment. So treating Hep C has other benefits we see in here as well. So where are the challenges today and tomorrow for Hep C? Most of my work has always been in therapeutics, and you can see the therapeutics essentially is all done. 95% cure rate, you can't really get much better than that. We can optimize patient flows and treatment. But where the biggest gap is, I think, is where we can all address, like all of you can actually help in this context. BC probably has one of the best data sets, has the best data set in Canada, and potentially one of the best data sets almost in the world, where a large cohort of patients already been treated and tested, and because we do this centrally through the BCCDC, we can actually capture antibody levels or antibody tests. So this is data from 2012, looking at the cascade of care. A cascade of care essentially follows a patient during whichever disease process, and to see where they are in that specific process. So on the y-axis, it looks at the estimated prevalence of hepatitis C, and you think it's about 60,000 to 70,000. Then you look at how many patients or how many percent of patients are actually diagnosed, i.e. had an antibody test being positive, and that's 75% of that initial cohort. And then 56% have actually had the confirmatory RNA test that actually have presence of Hep C still there. And then before you get treated, you get genotyped. So if we lose, and only 36% of those 56% have actually got that point. And then a smaller proportion have got treatment initiated, and then a tiny portion have actually get cured. So you can see the multiple steps where we can actually intervene, where you can improve the overall care of the patient. So the biggest issue to us is not starting treatment. Once you get in my office, we treat basically everyone. There's very few reasons where we will not treat Hep C. The issue is really different levels on this cascade. So one is the screening of hepatitis C. We don't have adequate screening. And in those patients who are screened, who do know they have Hep C, they're not linked to care. So that's another place we need to address. And then once they're linked to care, this part truthfully becomes very easy. As long as they're linked to care, then they'll be treated. How does this evolve into 2017? And I apologize I don't have numbers here. This is actually not, this is not published. It's from Naveed from BCCDC. And it shows that we continue to have this stepwise decrease overall in the cascade. But we have done much better when we look at treatment overall. So patients who are getting treated, the cure rates have improved significantly. Where we used to have in the 50%, we're now in the 90% cure rates. We now have 15,000 patients in BC who have actually been cured of the Hep C, versus about 5 years ago when it was 5%. So this is improving, but where we are failing is up here. What about the US? I'm just going to forward this a bit here. Okay, so 2013 and 2016, baby boomers in this kind of dotted, and in dark or in solid is young adults. And these are patients who are found to be RNA positive, who are either linked to specialists or linked to primary care. And you can see the linkage to specialists is very poor. And those patients who are linked, a small proportion of them go on to get treatment. So similarly in the US, they have issues with linkage to care as well as potentially screening. If you look at the effect on the primary care physician, there are more patients linked to primary care physicians in the US, but very few of those actually get treated. So you can see this cascade is not an unusual phenomenon in Canada. It is truly seen around the world. So groups to prioritize for screening and linkage to care, which is I think where we can come in. Unfortunately, Hep C has been stigmatized. And I've put this in order of actually probably overall prevalence today when you look at Hep C. So baby boomer cohort, persons born between 1945 and 75. So anybody born between 45 and 75 should get screened. Not, have you ever done drugs or a tattoo or a dirty tattoo or nose piercing or ear piercing or any. So no, it's you're born between this date and this date, you should be screened. Just as you should have a mammogram, a prostate check, a fit test. I don't really care, but they really should be screened because 70% of our Hep C patients are in this cohort. The immigrants are unfortunately treated very poorly as well because there's no screening process within immigrants. And I'll go to that in a moment. History of injection drug use. So this is where everybody focuses. Yes, this is an increased risk. Majority of these patients actually get retested and retested and retested. So they'll have 5 or 6 RNA and antibody tests. The contaminated blood products, not to belittle, this has been a very big source of Hep C. However, most of these patients have been found and treated. High-risk sexual behavior is a risk, but when you look at the prevalence rates, they're actually a bit lower overall. So looking at baby boomers, this is HCV prevalence on the y-axis, and these are age cohorts. So think about how old you are for a second, and then think if you've been tested or not. I think most people here are over the age of 20, I hope. Okay, good. In blue is the males, and in red is females. So 70% of Canadians infected with Hep C fall within this cohort. So think about yourself and your families if you've truly been tested or not. And thereafter think about your patients as well, who you should be testing. This is a global map of Hep C and essentially the prevalence. We're in North America where the prevalence rate is 1%. If you lived in North Africa, the prevalence rate is 10%. If you lived in southern places of the Punjab, we have a large Punjabi population, the prevalence rate ranges from 5 to 8%. In places in Asia, it again ranges about 5%. What this tells you is any person born outside North America or Western Europe should get tested once. Please don't assume it was tested at the country of origin or at immigration into Canada, because it often is not tested. There's no mandatory testing. For HIV, we've mandated. For Hep C, there's no mandatory testing. And even if they are tested, the test does not follow them, i.e. they may not always be told, or the physicians are not always told of the status. So it is worthwhile testing these immigrants. If you actually captured all the patients born between 45 and 75, and this cohort of patients, you'll actually find about 90 to 95% of Hep C that's prevalent. The 90-95% Hep C today. Okay. What about treatment of Hep C? I mean, this is an evolving area. This is just one program looking at telemedicine in inmates. Obviously, it's challenging to get inmates to come to your office, etc. And so how can we best provide therapy for these patients? I see them in my office, but I think there's better ways, and this is one of the more reasonable ways, I think. This is a patient population, a patient study, 800 patients. They found 110 of the 800 to have antibody positive, 86 are RNA positive, and they actually did a telemedicine aspect of trying to cure them. And you see the cure rates are at 90%. And when you look at the cost saving, which was significant cost saving, because you don't need transport, you don't need any particular link to physicians, and it can all be done where they are. So telemedicine is particularly useful in these kind of settings, or the rural settings where access is an issue. Australia has gone ahead leaps and bounds from Canada when you look at the overall care of the Hep C patient, and they've got integrated clinics not only for hepatitis C, but also for nurse-led treatment for Hep C, as well as GP-led clinics. And this shows that the cure rate, in no matter which clinic you treated in, is about the same, and just over the 90%. In the liver clinics, there are patients who are cirrhotic at a high proportion, a third. 5% are decompensated. So you don't see this so much in the GP clinics or the nurse clinics. But it does show that those patients who are more simple to treat could be treated by other practitioners. It doesn't have to be specialists per se. In our team, I have 2 nurse practitioners up in Prince George. I have a team in Surrey, one person assisting on Sunshine Coast. So there's a number of different models to try and improve the treatment efficacy, the treatment uptake in communities. So in summary for hepatitis C, we have real-world excellent virological data which mirror the clinical trials. The concern is that loss to follow-up patients. So we really have to follow up on those patients. Cure, I've shown without a doubt, improves long-term outcomes. Not only cure improves overall mortality, risk of cardiovascular disease decreased, liver cancer is decreased. So there's really no question of who to treat or not to treat. You should really treat everybody with hepatitis C. The current challenge is really the cascade of care. And I think that's where all of us come in. You know, all the baby boomers should be screened. Immigrant persons should be screened. And you see a lot of these patients, obviously, in your clinic. Persons who use drugs should be screened. There's sometimes linkage to care issues within their practitioners, i.e. who they're going to be seeing and not seeing. And you know, that's usually addressed mostly in the primary care aspect than anything. And there are going to be certain programs to try and address this as well. Okay, I'm going to go on to showing how the area of hepatology has really changed. And this looks at U.S. liver transplantation by etiology. And I'm going to just focus on the red box. And this looks at decompensated patients who have liver disease going under liver transplant in the U.S. In the solid bar is Hep C as an etiology. On the dash bar, large dash bar is NASH. And on the bottom here is Hep B. And you can see with Hep B, more or less, these drugs we have are very effective. Rarely do we have patients with liver failure getting a transplant. I can't remember the last time you transplanted a liver failure patient. Liver cancer is separate. This is liver failure, okay? When you look at Hep C, you can see this sharp decrease when you have DAAs introduced. I've not sent a Hep C patient for decompensated liver disease for a transplant in over a year. When you look at NASH, that's significantly up. I have more patients with fatty liver disease who have decompensated liver disease in my practice than I do of alcohol, Hep C together at this point. Certainly outweighs alcohol. So I used to always present the slide as the next epidemic, and I really think it is the present epidemic. So when we look at fatty liver disease, it's important to understand there is a spectrum of disease. You see in the first histogram, really fat within the liver. And that's what non-alcoholic fatty liver disease is, purely steatosis, so fat within the hepatocytes. And when there's fat in there, you do get some apoptosis of cells, so cell death and inflammation. And that's why you see all these tiny blue cells. And that's inflammation within the liver itself. So that goes from steatosis to steatohepatitis, or inflammation of the liver. And those patients will get progressive fibrosis and lead to cirrhosis. The question has always been how to identify these patients, where they are, and how to get them. And that's always challenging to truthfully do. But it's not until you get this NASH component where you really get a higher risk of cirrhosis. It would be uncommon to go from bland steatosis to cirrhosis. You really should pass by this NASH component. So when we look at the pathogenesis of fatty liver disease, we think there's multiple hits. The first hit, which is the production of steatosis. How do you get fat in the liver? And it's really free fatty acids which go into the liver, and it's thought to be in the context of insulin resistance, the metabolic syndrome, which we'll go into, and then genetic factors potentially. And you get fat within the liver, and after that, the second hit is really that inflammatory process where you get apoptosis and inflammation and oxidative stress, where there's inflammation within the liver, and eventually you get a third hit where you get fibrosis or the scar tissue from stellate cell activation into the liver. This is disturbing. I know we are in Canada, but obesity trends in the US is shown here in 1990, 2000, and 2010. This does not include 2018, obviously. So in the bluish are the rates at about 10%, in the dark blue 15 to about 20%, the orangish 20%, and 25%, in red over 30%. If you remember, we're not exactly saved. We're right here on the border between Canada and US, and we function very similarly to a US state in obesity rates as well. But you've seen how in the US, you got this 30% risk of obesity in 2010. Last year, when we looked at Canada, and we don't have breakdowns of rates within provinces per se, but the obesity rate in Canada is now at 30%. So BMI greater than 30% is now at 30% in Canada as well. So we're following very similar issues as the US, because we all get biggie fries and biggie drinks and whatever the heck it is. So is this truly a North American phenomenon? And the answer is no. This is actually a beautiful global diagram to look at fatty liver disease in different areas. So we don't have much data in Canada, but Canada follows probably US, okay? And if you look on here in the US, in this kind of orangish circle here, this is the rate of fatty liver disease. And in this bluish area here is the rate of NASH. So 30% of Americans and probably Canadians have fatty liver disease. And probably 5% have NASH, or that inflammatory component, which will go on to get cirrhotic and or liver cancer. If we look at South America, their rates are just as high. In places in Europe, you see similar rates. In Asia, you see similar rates as well. In Japan, who you think may be immune and everybody may be slimmer, is not really necessarily the case, because you see similar rates of fatty liver disease and this high rate of NASH as well. It's really Africa which has somewhat lower rates. What this tells us is there's probably an environmental aspect, but also a genetic aspect when you look at fatty liver disease, which we truly don't understand. But it is not a local epidemic, it's really a global phenomenon that we worry about. This is borrowing data from the internists. The Dallas Heart Study tried to look at the prevalence of fatty liver disease, and they assessed it with ultrasound. And 30%, see this number keeps coming back up, 30% of patients in this study had ultrasound findings of steatosis, i.e. fatty liver. The NHANES study, which has 16,000 patients practically, looked at liver enzyme elevation as a poor surrogate marker for inflammation and found that 5% have elevation of liver enzymes, which is found to be secondary to NASH in all likelihood because viral were excluded. So this 5% continues to ring on along the way. And if you look at overall, compared to Hep C, that's 3 to 10 times more prevalent. This is from the NHANES data again, and it looked at predictive factors for fatty liver disease. And diabetes has an 18-odd ratio, 18 times more likely to cause significant scar tissue or fibrosis in patients with fatty liver disease. So you can see from these certain predictors of those patients who will have advanced liver disease. So diabetes, obesity, hypertension, and obviously as you get older, you get more fibrosis with time. So those tend to be the strongest factors. Diabetes itself is the most predictive factor when you look at progression to cirrhosis. So this is patients with fatty liver disease, no diabetes or diabetes, and you can see a high proportion will end up being cirrhotic versus patients without diabetes. When you look at the prevalence of cirrhosis in fatty liver disease, it's similar to that of alcohol and Hep C. But the problem is society is not being that ready to accept, one, fatty liver disease, and two, developing cirrhosis from fatty liver disease. Patients, even after they see me, they can't believe how much fibrosis they even have when you have the conversation. And they go, well, I'm a bit overweight, it's okay, it'll all disappear, it's all good. But there's just not that worrisome aspect. If I told a person they have diabetes, they're going to be all into, well, my kidneys are going to be bad, I'm going to lose my foot or my toe. But they don't think that way in fatty liver disease. And when you look at risk factors, it is going to be a major issue when you look at mortality. So if you're going to take away from Hep C that you're going to do me a favor and screen patients and family and friends and immigrants, what you're going to take away from here is that mortality in fatty liver disease increases as we get more damage on the liver. This is all-cause mortality on the y-axis, and this is stages of fibrosis on the x-axis. Remember I said that no fibrosis is stage 0, minimal fibrosis stage 1, moderate stage 2, and then extensive fibrosis is stage 3 and 4. But you can see an inflection point at moderate fibrosis, which is really worrisome because you don't have to be cirrhotic to develop a higher risk of all-cause mortality. This is all-cause mortality, increased cardiovascular as well as malignancy. If you have liver-related mortality, the inflection point, as you'd expect, is F3 fibrosis. Once you get F3, there's a much higher risk of liver cancer as well. But essentially, fatty liver disease is bad. Unless you have very minimal disease where you may actually improve to some degree, even moderate disease, I personally think in the future is going to be a lot more worrisome because of this all-cause mortality. So how do you diagnose fatty liver disease? It's challenging because it's often in diagnosis of exclusion and probably risk factor driven. We have different mechanisms. The diagnosis on ultrasound by steatosis is not standardized. We're talking to the chaps here to try and see if we can standardize at least our ultrasound reporting of it. It should catch steatosis of greater than 20% for the most part. Certainly even over 5%, we should be able to catch it on the ultrasound, but not always. We have and I'll go into FibroScan, we have certain CAP scores on that where we can address and see how much steatosis there is in there. This may come to the role of liver enzymes. You're going to look at your high-risk patient, your diabetic, you're going to look at your dyslipidemic and your obesity patients. Those are automatically high risk. If anyone has elevated liver enzymes, that should be taken seriously. Elevated liver enzymes is bad. And that probably is the poor man's indicative aspect of NASH. And that's that inflammatory aspect which goes on to cause cirrhosis. So anybody with elevated liver enzymes, they should be seen for potentially fatty liver and exclude obviously Hep B and Hep C. Fibrosis staging, and this is something you can do in your clinic, and I'll go into that. Non-invasive ways, FIB4 and APRI, the NAFLD fibrosis score, and I'll go into that in just a moment. FibroScan is another non-invasive measure, and really the liver biopsy has fallen in the way of the context of the non-invasive measures. Google is always a very useful tool when you look at life and when you look at non-invasive fibrosis. So if you actually Google FIB4, you'll get from the University of Washington this calculator. And it's pretty good when you look at the AU-ROCs, so about 80% ROCs on these ones. And all you need is the patient's age, AST level, and platelet count. And in this blue box, it tells you those patients who will have minimal fibrosis or more advanced fibrosis. It is only good to predict or exclude extensive fibrosis. So you'll be able to weed out the majority of patients on a tool like this who does not need to be seen in specialty care by simply doing the platelet count as well as the AST. Oops, my mistake. I'm sorry, I just flipped this last night. So I'm going to take that back. This is FIB4. The FIB4, and I put this first because it's something that I think we should get used to. ALT is needed, AST is needed, age is needed, and platelet count is needed. And I think over the next few years, this is going to be one of those more accepted terms where you'll be using that to evaluate any patients with liver disease in the community. We're hoping to try and get this integrated into the lab system where if you get liver enzymes and a CBC, you'd automatically get a FIB4, just as you do with creatinine clearance and all that, GFRs today and all that, that this would prompt somebody to say, this is a higher risk patient, they need specialty care or they need a referral versus a lower risk patient. That would be the ideal setting. We just have to get a bit of buy-in from the private labs. APRI is useful, but not as useful as the FIB4. It uses the AST and platelet count. This is a more involved scheme. It's a NAFLD fibrosis score. Again, it's something you can do in your clinic, looking at age, BMI, whether or not they have diabetes, AST, ALT, platelets, and albumin. It's not more accurate than the FIB4, so I would personally just use the FIB4 if I was in clinic. We do use this in our databases, but more in the context of being specialty care, I think. The FibroScan is a machine we do on everybody who comes into CS, and it's a very non-invasive measure of fibrosis. Essentially, you have an ultrasound-looking type of machine. You have a probe, and goes onto the right costal margin, and you get 10 taps. And from this, you get an elastographic view or a stiffness of the liver, which translates to fibrosis. What we now have as well is software to look at steatosis separately. So in a patient who has minimal fibrosis, we can actually look at how much fat burden there is in the liver, and it's somewhat predictive. I have to admit, they sound a lot cooler and sexier than they really work in real practice, but it is the best measure we have today. So it is a very useful tool, and the best one there really is. How do we manage non-alcoholic fatty liver disease and NASH? And really, it's that pyramid as you're used to in so many things in medicine. On the bottom, it's really lifestyle modification, which we'll talk about. Integral to this is actually the treating the components of the metabolic syndrome. So if they have diabetes, optimizing their diabetic care, optimizing the dyslipidemia. We as yet don't have liver-directed pharmacotherapy. I don't have a drug I can give you for fatty liver disease or for cirrhosis related to fatty liver disease. And then we're stuck essentially managing the complications of cirrhosis, be it decompensated liver disease or liver cancer. Let's look at the pyramid when you look at lifestyle. So this looks at the percentage of weight loss that's actually required to get improvement of fatty liver disease. The challenge with lifestyle in fatty liver disease, it's not a 1-month project. It is not a 3-month project. I tell patients behavior is the most difficult thing to change in a person's life. If I gave you a pill a day, it would be much easier. All the patients say, no, of course not, Ramji. A pill is there. I hate pills. I go, well, think of it this way. Truthfully, people will accept a pill, but when you say you've got to exercise and you've got to diet to improve things, it's much more challenging because you have to do this for a lifelong event. So whatever you do has to be until you're the age of 90 is what I normally say. So if you're going to improve steatosis, you need a weight loss of greater than or equal to 3%. If you're going to start improving inflammatory component, you need a weight loss of 5%. If you're going to resolve the inflammatory component, 7%. And if you're going to improve some regression of fibrosis, you need a 10% weight loss. But this is a sustained weight loss, i.e. indefinite sustained weight loss, not a one-time event, which is where the major folly comes in. So the effect of diet in fatty liver disease, you have to limit the total caloric intake. That's an ideal situation. And you really need to aim for a specific nutrient composition. The worst thing in this world is fructose. So sugar is just bad. It is absolutely terrible. And you'll be amazed how many people drink pop on a regular basis and juices on a regular basis, and especially with our younglings. I have this chap who sees me from Children's Hospital who's 12 years old, and he has cirrhosis. That's my youngest cirrhotic, is 12. And he sees me every 3 to 6 months. And the sad part is the family doesn't get it. Before he comes in for a FibroScan, He had eaten. I said, well, what did you eat? KFC. And, it's not like I haven't seen him for a long time. I've seen him for a year and a half. But it's not truly completely his fault. It's more family fault. Some people, people don't always understand how to change lifestyle despite going to dietitians and all that. So take out the sugars. The other part is carbs. Carbs are evil as well, but we obviously have to have some carbs. So you want to really have more of a keto-type diet, high protein, high veggies, lower carbs, and just enjoy the sugars once in a while, and that's about it. Coffee is good. Coffee is good for fatty liver disease, so you'll all be thrilled about that, I hope. What about exercise? It's not enough simply to limit your lifestyle in the context of diet. Really, exercise is a key component as well, really, to burn anything off in the liver and other organs. And it's not clear whether you need aerobic or resistance training. There's not enough data on this. I actually suggest both, and I use that 40 minutes, 5 days a week if you can. Usually patients manage to get about 4 days a week, about 2/3 aerobic and about 1/3 resistance training. It seems to do most of the trick. Again, it has to be sustained, which is challenging. What else should we do? Obviously, talking about the pharmacotherapy, dyslipidemia, diabetes. Statins are safe. You see there's elevated liver enzymes. Give them more statins. It's good because you're treating the dyslipidemia more than anything else. There are a number of different drugs which have been looked in fatty liver disease, and this is pure fatty liver disease without diabetes or dyslipidemia, and you can see the thioglycozones, the statins, metformin. Really nothing has panned out when you look at that in the context of pure fatty liver. Vitamin E could be used. Very few of us actually use it. I barely use it because some concerns of doses. And then when you look at overall the treatment algorithm, I know this is a complex slide, but treatment algorithm for fatty liver disease, you have patients with no damage really, so just the steatosis, patients with inflammation of the liver, and patients with advanced fibrosis. And that's probably how we're going to look at this in 5 years to 10 years' time. The cause of death in these persons with no damage is going to be cardiovascular. And even in those patients with minimal fibrosis, you're going to get mostly cardiovascular, but at a much higher rate. And then in those patients with more advanced liver disease, which actually is going to be close to 5% of the population, which is a staggering thought, is going to be liver-related outcomes. So everybody needs lifestyle modifications. That's kind of the baseline. Bariatric surgery, I won't show you another slide on this, but mention that bariatric surgery, I'm convinced, does have improvements. Okay, when you do liver biopsies a year or 5 years out, you see improvement in fibrosis as well as the steatosis component. Pharmacotherapy, this is going to be measured at different contexts, i.e., there's some drugs which are going to be used to inhibit fatty acid synthesis, some in the context of bile acid synthesis, which is thought to decrease the progression of inflammatory components, the true anti-inflammatory components. And what we really need is the antifibrotics, those drugs which can be used in advanced liver disease and bring a patient from F3 or F4 down to F1 or F2. There are a number, I've just shown you the number of a few drugs in phase 3 clinical trials. Phase 2 clinical trials in fatty liver disease encompasses 28 molecules. In phase 3, we just have a few. One of these, unfortunately, the selonsertib, has not shown any great data when you looked at the outcomes about a month ago. So, it's still waiting for some of that data. The OCA molecule, which is on market now for PBC, showed modest improvement in patients with cirrhosis, but the side effects are quite high as well. So, we're still at a very infancy when you look at even drug development, unfortunately, even though there's a lot of thoughts about it. The challenge with fatty liver disease, it's probably because it's so much of a heterogeneous disease. We've come from Hep C, where a cure is a cure. In fatty liver disease, you've got your diabetics, you've got your obesities, you've got your dyslipidemics, and I think we can't treat everybody as the same. And that's why it's been challenging for this therapeutic area. So in summary, fatty liver disease is very common. I should put a very in front of that. With progression to NASH in a significant portion of persons developing cirrhosis, you have to evaluate them in the context of ethnicity, potentially, obesity, type 2 diabetes is critical, and that's why I think it's so important for the internists and the metabolic syndrome. Staging of fibrosis, and you can do this in your office. We physically cannot fibroscan 20% of the population. It just can't happen. But certainly when you're looking at low numbers of patients to evaluate, that's much more doable. Patients with elevated liver enzymes are higher risk, obviously. Lifestyle modification is really the mainstay of therapy because that's what we have right now. There's been a lot of discussion in the last 6 months with endocrinologists and other internists of why the heck should we bother in assessing fibrosis if you can't do anything. I take more of the role of it's important to know where a patient is in this disease process, because if they are advanced, what you can do is screen them for HCC. The drugs we don't have today, but they will be here within a year's time. So it's not a long ways to go before we do have some pharmacological measures for those patients with advanced disease as well. So it's good to know who and where they are right now. Okay, thank you very much. I know it was a bit of a whirlwind within 2 different processes, but I'm happy for any questions, either one or not. Was that clear?
Questions? Can you use your, Scott, can you use your button?
So, okay, shout, I'll repeat the question.
Anyway, do you have any favorite, obviously, having people lose weight, I mean, they all want to be on a special diet that they take for 3 weeks. They want to lose, 50 kilos in 3 weeks and then go back to the KFC.
Yeah.
So do you have any sort of...
Yeah, so so when I talk to them about, so my first visit is to say, listen, we need to do this lifestyle modifications. What I actually tell them not to do is lose weight too quickly. What I learned very early in my career was that the anorexic patients, they develop fatty liver disease and significant fibrosis because of when they lose weight rapidly, you get this oxidative stresses and you develop inflammatory changes and fibrosis changes. So they should actually lose weight gradually. And I don't focus on weight. I actually say what you need to do is to exercise, and I give them exactly what I said. And for my diet, I'm quite critical on the context of protein as well as green veggies, and then try and decrease. I talk to them about where the sugar comes in, because the sugar is an easy one to leave out. Because once you lose a taste of sugar, you're okay. And I tell them I don't like to make them miserable. If they like cheesecake, have a small bit of cheesecake once a week, 3 times a week, whatever you want, a chocolate or ice cream, whatever it is, but small amounts. So moderation of your size as well, and the lower carbs. So not no carbs, because some patients take this to another limit. And then the exercise. But it's so very much that keto diet, but more liberal, because you can't sustain a keto diet. And I say, whatever diet you need to do, you need to be able to sustain this lifelong. So it's kind of working with them on what diet they have. So much of this is so maternal. It's funny, I spend most of my consult being maternalistic and really looking at what they're taking.
Do you have any handle on your success? I mean, I know that.
Yeah, so anecdotally, and we should be able to show some of this, but we do get improvements of liver enzymes. Norina probably hates me because she tries to recruit them into clinical trials, and I wait 6 months before I let somebody in, and you'll see FibroScan levels come down, steatosis level comes down, and if I had to say how many percent, for people who follow it, probably about 50, 70% you get improvements, particularly liver enzymes. I see some of the renal transplant patients. There was this chap, Korean chap, who was trying to give a kidney to his wife and elevated liver enzymes, and he had fatty liver disease and no fibrosis. The kidney guy says no transplant. He had fatty liver disease. ALT was moderately high. He was having 3 triples a day from Tim Hortons and ice cream. We managed to take that out, do a bit of exercise. Liver enzymes normal, no steatosis on camp. He gave his kidney. So we do get, and I know it's anecdotal, you have to nag them. And I actually am very happy when they bring a spouse, because as you know, no, you don't know, spouses never nag you, but it's very useful to have somebody else in the room, because they will really remind you of how things should be done. You need somebody else to kind of echo in. The challenge is physically, you can't see these patients over and over again to do that. So, and as you know, it's sometimes challenging with primary care linkage.
Yes.
Yeah, Fanny?
In the Asian population, we see a lot of skinny patients with fatty liver disease. Do they have the same evolution as the Asian?
That's brilliant. Yeah. So Fanny's question is about the skinny patients who have fatty liver, and so Asian BMI is a bit different from when you look at overweight compared to Caucasian. There is what we call lean fatty liver disease, and that's why I think fatty liver disease is so heterogeneous that you could still have fatty liver even if you're reasonably lean. Those patients will still tend to have the same risk factors. I think there's an ethnicity component of that. Most of these persons, and I'm not been to China enough to say this, or practiced in China at all, really. But when you bring patients from immigrant populations, you will see the sudden increase when they move to Canada. And it's usually lifestyle oriented. They come in, an immigrant patient usually has 2 jobs. They don't care about their health as much, they care about their family's health. We have way too much access to sugar and carbs in North America. and there's less exercise. So I think there is that component of it, but I think there's an ethnicity component as well, where we know that the Latinos have a higher risk of fatty liver.
So mine does work. The hard question from my perspective is, when do I either get a fibro scan or send the patient to you? I see ASTs and ALTs of 50, 60 all the time, and I can't be sending all of those.
Yeah.
The thing you mentioned about the fibro 4 or whatever, that would be very helpful.
Are you internal or endocrine?
No, I'm steward advisor in endocrinology.
Yeah. Oh, okay. Oh, very nice. So I've been talking to some of your colleagues because this is a very big issue in the context of both of what we do. And I think to be the safest measure, most reasonable measure is really that FIB4. Because as you say, we cannot see 100% of diabetics. But the FIB4 is got an ARSC of 0.8 to 0.85. And it'll find that patients who have moderate to extensive fibrosis, or at least exclude those patients who have lower values, and I can show you that. But the FIB4 is what you really want to do on all your patients. And an abnormal liver enzyme is an abnormal liver enzyme. I know it sounds so obvious, but it is abnormal. And what's interesting as well, as patients progress on fibrosis, the liver enzymes will go down as well because there's less hepatocytes. But that's where the platelet count comes in. So doing the FIB4, I think, is very reasonable in primary care or specialty care, and then using that as an algorithm, who should send and who should not send.
Can you
so,
know what the
he put it up. So I guess you need the AST, ALT, and the
age,
platelet count.
age and platelet. Yeah.
We don't always get CBCs on patients, but that would be an easy thing to change. If you can get the lab to buy in, like EGFR, and have it there, then it would be very easy to do. To be honest, I'm not going to go calculate. I've got so many other things to do with my diabetic patients each time they come in. Yeah. But if we can get the lab to buy in, that would be a tremendous step forward.
I think. As a start, if it's possible, at least those ones with elevated liver enzymes to get a platelet in. And then, it is going to be a challenge. I've been chatting to some of your group, and we can chat after that. But the lab, hopefully, you know how long it takes. We just started this discussion about 6 months ago. It's a lifelong process. Okay. Thank you very much. And thank you for all the questions. I'm around if you need. You know, I recognize it.
That's good.
Very leisure. I did single system. 20, yeah, exactly. 20-minute private follow-up. Yeah, it's like an ortho follow-up. Yeah, I see 70 people a day. It's all. Yeah, that was I thought the same thing. That was interesting. Hey.
So
we should calculate FIB4 for that guy.
Is your triple here? Don't want to leave that behind.
diet.
Maybe now it's just these packets of sugar and a stick of butter.
I think I put that in, but I'll.
I mean, if you have
So no, like that.
And if it's fine, I'm going to. Thank you.
No, but
Oh, but his liver enzymes were normal.
But his bears are so I'm using that as
So that's what they actually say.
Computer filling in the numbers. No, it's not. I'm curious to see because I don't. All that's getting is.
And the place to start would be if we don't have CBC, but not AST, so that we don't have CBC for how our standard. So if I think I would start with the lab, and if we can get the lab to do the calculation, then come to us, and I think it's very easy for us to that AST and CBC.
So are you using ferritin at all as a
I think it's a good inflammatory marker, but not so much in the context of progression of liver disease or stage. So most patients are referred with elevated ferritin and then an elevated GGT level from primary care, and they always assume chromatosis, and the ferritin is like 700 or 800. And eventually, you do the transaction, it's normal.
No, I know. But, when they have fatty liver disease, does ferritin figure into how you counsel the patient?
Not specifically, but it does give me an idea that there's more inflammatory component. What it's not shown in literature is what it means, as in ferritin of 600 is a prognosis worse in a patient than ferritin of 300.
You counsel the patient. If they have a normal liver enzyme and a high ferritin.
Yes, then I would. Yeah, and even with patients with bland steatosis, I tell them where they are. I go, look, you're at a good time because you change this, you're not going to go on to develop stuff. But those with ferritin elevation, you go, look, this is an inflammatory marker. Because patients are worried about the ferritin, right? They go, oh my God, my iron's up. You go, this is why. Yeah. You're going to lose this inflammatory component.
Okay. Thanks.
Right. And he's a typical Asian male. I know this part perfect. Not dramatically,
well, you know, like I said, Sabrina, hopefully we'll get to room to one of the residents what you actually have to see what percentage of things are. Maybe it might be a good quality aspect of the program as well. I have to say there's no CBCs.
No,
and elevated to evaluate fibrosis.
But I mean, there often is a CBC on the chart, but it's not part of our standard. Yeah. So it's a low platelet count that's more concerning.
But I think, like you say, it's fun. So not that because it's just like the first time I treat it. And that may be the easiest because then it's like, it's like one form, and they go once and they come with you to the clinic. So we're working internationally.
Your call will be disconnected.
Fatty liver disease within your guidelines next year.